All right, last show of the year.
Talking this morning about some of the grave dangers of isolation in this pandemic. Its impact.
Early in the course of the COVID-19 pandemic, everyone was staying at home. While we called it social distancing, it would have been better to call it domestic congestion.
The public health measures meant to protect lives are putting some people at even greater risk.
Parents stayed home from work, kids stayed home from school. We were forced to live and interact with our partners, our parents, our siblings, and our children 24/7. We couldn't even go anywhere because everything was closed. It was a prison for families.
The rise in rates of domestic abuse across the country.
Now, I love my family. This was not a problem for me. My wife, Erica, was able to do a lot of her work from home, and our 1-year-old daughter, Sophia, well, she tried to keep us from getting work done. But for some, staying at home created a real problem. With a rise in domestic congestion, there was a rise in domestic abuse.
Domestic abuse, domestic violence.
Crisis lines across Canada are getting a surge in calls right now from people who need help.
The United Nations Secretary General Antonio Guterres reported that the number of domestic abuse incidents rose by a third early in the course of the pandemic.
There will be a significant increase in family violence reporting and family violence crime.
20 to 30% increase.
In India, the first week of lockdown resulted in a doubled rate of domestic abuse reports.
India has been under a 3-week lockdown which started on March 24th.
Australian investigators observed a 40% decline in overall crime, but there was a 5% increase in domestic abuse.
And I suspect that people will stay in violent relationships because it will be that they won't know what else to do.
It's almost unbelievable. This is a tragic social consequence of the pandemic. We discussed some of the other collateral damage from COVID-19 on our recent show, episode 175, Call Your Mom. But in today's program, we're talking more specifically about traumatic brain injury. Not specifically in reference to COVID, but the severe kinds in which rapid accelerations and decelerations of head movement stress the cortical neuronal axons and fundamentally damage the neurofilament subunits, diffuse axonal injury, with the resultant and unsurprisingly broad range of consequences spanning mild memory impairment to hormonal dysregulation or even coma. Welcome back to Brainwaves, a podcast about neurology and medicine and all the fascinating science and history that come with it. I'm your host, Jim Siegler. Stay with us. This week on the program, I'm joined by Dr. Monisha Kumar.
I'm Mona Kumar. I'm a neurointensivist at the University of Pennsylvania and director at the main campus Neuro ICU.
And a former mentor of mine from residency, fantastic teacher on rounds. I was lucky to get her to join me on Zoom.
I'm excited, and it's a sort of different medium than I'm used to. I've never actually...
When I called up Dr. Kumar to join me on the show, in full disclosure, she admitted that DAI is not really her expertise. But if we're being honest, what clinician is an expert in a concept that's so vague? Diffuse axonal injury, DAI, is a histological process, and it practically requires brain biopsy or autopsy to make the diagnosis. As we'll discuss in greater detail later, your first parenchymal image, a brain CT, is typically normal, unless it shows other signs of trauma like diffuse subarachnoid hemorrhage or subdural or epidural hematomas, which create a number of problems for clinicians, ranging from difficulties recognizing DAI to prognostication.
Because I think the problem is, how do you extricate DAI from the other TBI that they have?
Exactly. But regardless of whether these blood products from traumatic brain injury are present, nearly half of all cases of significant TBI are accompanied by some degree of DAI, and practically all cases of TBI in which there was a loss of consciousness.
We're already talking kind of the worst of the worst.
Characterized in detail by Adams and colleagues.
In a paper from 1982.
From a case series of 45 patients with, quote, non-missile head injury. The concept of post-traumatic white matter disease was first described 30 years earlier by Sabina Strich.
Really, the seminal work identifying the pathology of axonal degeneration was done in the 1950s.
This paper reports the findings in the brains of 5 patients.
Strich's original report describes the nearly immediate and prolonged comatose state of patients with no apparent cranial or parenchymal injury.
That is, there were no fractures of the skull, no intracranial hematoma, or lacerations of the brain, and in particular,
It was only after the patients had died that Dr. Strich uncovered a widespread and disturbing explanation for the patient's
a
coma.
diffuse degeneration of the white matter of the cerebral hemispheres.
What is the typical story for a patient in whom you suspect DAI?
So I guess the classical description of a patient with DAI is one where the patient presents in a coma, but the head CT does not have an obvious mass lesion. I would say more typically, DAI is present in patients with moderate to severe TBI who experience an acute loss of consciousness.
And for the most part, the loss of consciousness immediately follows the head injury, unlike the lucid period you might see with an epidural hematoma. And sometimes the impaired consciousness can last a while.
I would say the most common presentation is that they're comatose initially. There have been a couple descriptions where patients present with a lucid interval and then become comatose. I think it's interesting, actually, because I think it gets to a little bit to the pathophysiology, which, it's important just to know what DAI is. I think we talk about it a lot, but what does it actually mean? And I would say that DAI reflects a process of widespread axonal damage after trauma. And we're still
Diffuse axonal injury, as the name suggests, and as Dr. Kumar has illustrated, can occur in nearly any white matter region of the brain. The most common sites of injury include the parasagittal white matter, the corpus callosum, and the pontomesencephalic junction, which also happen to coincide with most of the regions where injury can be visualized on brain MRI.
It can actually be primary or secondary. And we talk about primary and secondary injury after trauma a lot, but this is more primary axotomy.
Basically, transection of an axon.
Or secondary axotomy. And so the way it really works is that in primary axotomy, you have the traumatic insult that causes deformation of the brain. And that deformation puts stress and stretch and shear strain on the long tracts. What that does is it actually distorts the axonal cytoskeleton and microtubule function. And that disrupts axonal transport. And that's really the critical piece, is the disruption of axonal transport. Because acutely what happens, so in primary axotomy, the failure of axonal transport leads to accumulation or buildup of the transport cargo.
Neurotransmitters and various proteins, including the amyloid precursor protein.
And it sort of gets stuck at the area of injury.
And over time can progressively aggregate within the white matter, leading to neurodegenerative conditions.
And it causes swelling. And eventually that pinches off from the distal part of the axon. And that distal part of the axon undergoes Wallerian degeneration. And the proximal part leads to this kind of retraction bulb,
which you can see using a simple silver stain and is the histopathologic hallmark of DAI, occurring within 24 hours.
But then over the next few days, you can actually have additional injury
as the surrounding microglia begin to cluster around regions of axonotmesis, which is another word for the axon transection process, and voltage-gated calcium channel and NMDA receptor dysregulation,
cytotoxicity,
lead to a rapid influx of calcium,
loss of ion gradients,
activating calcium-dependent caspases and other proteolytic enzymes, which play a key but incompletely described role in DAI.
And that can also lead to the same sort of axonal swelling, which then leads to secondary axotomy.
And this term generally refers to the process whereby axons that survived the initial traumatic force eventually break down as a result of this calcium-dependent oxidative apoptotic process. With Wallerian degeneration, I know it takes time for you to see that type of gliosis or those types of structural changes on the brain with scans. When should we expect changes to be seen on scans, or do we even see them?
Unfortunately, with how sick these patients are, or with how not sick they are and how quickly they leave, we're imaging primarily with CAT scan. And so you're not going to pick up some of the early changes that you might see on other imaging. But later, weeks to months out, you will see atrophy and you'll see loss. And so you can certainly see it then, but it's not as readily evident.
DAI is typically hard to see on a CAT scan, as Dr. Kumar mentioned. Sure, you'll see the convexity, subarachnoid hemorrhage, or the subdural associated with the trauma, but sometimes there's no radiographic evidence of any parenchymal injury, on CT scan that is. MRI can show evidence of post-traumatic microbleeds on GRE or SWI sequences in over half of patients, according to several cohort studies, and there are ways you can classify DAI based on the location of microbleeds, which can also be prognostically useful. But grading of DAI from that seminal paper by Adams and colleagues in 1982 broke it down into 3 histopathologic grades:
mild, moderate, and severe.
With grade 1, or mild disease, characterized by
microscopic changes in white matter of the corpus callosum, brainstem, cerebellum.
And grade 2, or moderate DAI, being more severe with
pathological evidence on a gross scale and focal lesions in the corpus callosum.
And lastly, severe DAI.
Grade 3 was focal lesions in the dorsolateral quadrants of the rostral brainstem,
which correlated with more comatose state and generally poor probability of recovery, as we've seen in radiographic studies of DAI.
That's how it was defined in the original paper by Adams. In terms of whether we use that clinically,
that meaning the original histopathologic grades of DAI described by Adams,
I would certainly say if we see evidence of grade 3 DAI, it definitely catches our attention. The grade isn't necessarily recorded, say, in our notes.
Before we go any further, before we get into all the challenges of prognosticating a patient with a normal head CT in a comatose state, I'd like to take a step back and acknowledge several of the clinical steps that critical care docs like Dr. Kumar have to address before arriving at DAI. What other medical conditions have to be excluded in a patient who has coma or a severe impairment in consciousness?
Altered mental status.
And yet normal structural neuroimaging.
Normal brain imaging by CT. Of course, we're going to be thinking about doing a metabolic workup for excluding other causes of coma.
Particularly anoxic brain injury, or hypoglycemia, which can be the metabolic equivalent to anoxic injury, or hyperammonemic encephalopathy, which may manifest with subtle changes of global cerebral edema. Then there are rapid fluctuations in sodium, which can be tricky. TBI can cause cerebral salt wasting with hypovolemic hyponatremia, and you might be worried about cerebral edema in that case as well. But most of these labs come back in your standard chemistry. In the right context, you'll consider a second-tier evaluation.
Obviously, a tox screen, infectious workup.
And infections can be systemic, or they can be neurologic, so you might look there.
Doing a lumbar puncture.
And save some fluid, because you might not know which pathogens to look for at first pass.
And probably will culminate in getting an MRI.
Which will, help rule out brainstem stroke or bithalamic infarcts and many other radiographic processes that you see with the aforementioned metabolic, toxic, and infectious etiologies that we just covered. But also, maybe you'll pick up evidence of DAI. Often with severe head injuries, like you would see in DAI, sometimes there can be something that clouds the picture. Like maybe they have a subdural or they have a traumatic subarachnoid hemorrhage, something that may raise your suspicion for seizure or another etiology of the patient's coma. How can you dissociate DAI from those situations, or can you?
Oof, that's a tough question. I would say that the classic symptom, again, is whether there's acute loss of consciousness or perhaps an altered consciousness out of proportion to the imaging. And as you pointed out, in the absence of seizure activity. So I think the first thing we would obviously do is to get the EEG and make sure that there's no seizure. But one thing that I think is very interesting is that from the TBI perspective, we really think about TBI as being a very heterogeneous disease. So, is someone who presents with a subdural the same as someone who has a contusion, someone the same who has just some, cortical subarachnoid that's traumatic? But one unifying pathology across all of TBI subtypes is actually DAI. And you can see DAI really frequently, no matter what the presenting subtype is. So I think it's a really important thing to always keep in the forefront of your mind, but make sure to exclude other things that could be confounding.
In other words, DAI represents a broad spectrum of clinical manifestations with a similar underlying histopathology.
No, absolutely. And that it's a progressive disease, right? I mean, this is something that, causes progressive degeneration potentially over time in a way that's very similar to other neurodegenerative diseases like Alzheimer's disease and things like that. And you can actually sometimes see these axonal retraction balls years later as evidence of prior TBI on pathologic section if patients, die for other reasons. So I think that there's a progressive story to this as well.
This progressive story Dr. Kumar refers to is the increasingly understood relationship between TBI and neurodegenerative disease. Over the last decade, there have been increasing histopathologic and clinical papers documenting long-term sequelae of even a single TBI event. and one well-designed, age-matched case control study from the UK involving post-mortem brains from 39 patients with a single TBI event and 47 brains of patients without any reported TBI, there were several important findings. Before this study, prior reports indicated immediately following TBI, amyloid beta plaques and neurofibrillary tangles could be found, and they might indicate an acute phase response. But whether these early changes persist, or even become more progressive with time, was unclear. So the investigators of this UK study took the 39 TBI brains and 47 controls, and they found neurofibrillary tangles widely distributed in the patients with prior TBI. Overall, it was only an absolute increase of 12%. 34% of controls had tangles too, versus the 46% of TBI patients with tangles. The prevalence of tangles among the younger patients was significantly more disproportionate. 1 in 3 of the young TBI patients demonstrated this neurodegenerative pathology, in comparison with only 1 in 10 of the young non-TBI patients. The association between TBI and neurodegenerative disease is becoming more and more concrete. We covered much of this in one of our earlier shows, episode 33, Controversies in Chronic Traumatic Encephalopathy, which you might also want to check out. Returning to the acute management of these patients, however, you've got your patient in the ED or they're in the ICU, traumatic motor vehicle accident, an unrestrained driver that was ejected from the car, or an assault victim. You've put DAI at the front of your mind, as Dr. Kumar has encouraged you to do. But short of brain biopsy or autopsy, is there anything else that can help you reach the diagnosis? And the answer is yes, imaging, but not with head CT.
Maybe CT picks up about 10%, but conventional MR definitely fares better. So the shear forces that are associated with DAI transect very small blood vessels that run in parallel to the axon. And so this results in detectable gradient echo and T2 star lesions. So the distribution of these lesions, when you see them in the corpus callosum, the brainstem, that's going to suggest DAI. It should be pointed out that susceptibility-weighted images are going to be more sensitive for DAI.
So you get your MRI, and you'll look through the heme sequences, your GRE or SWI or T2 star, and you'll look for those microhemorrhages in the deep white matter, especially the parasagittal frontal lobes, corpus callosum, and the brainstem structures. You'll also be looking for evidence of subarachnoid hemorrhage from trauma or a subdural hematoma that your CAT scan might have missed. But these deeper parenchymal microhemorrhages are going to rule in the diagnosis of DAI. One thing to keep in mind is that, especially in your older patients or patients who have significant microvascular disease, these microbleeds are not bad mimickers of underlying hypertensive vasculopathy, amyloid angiopathy, or other atypical angiopathies like CADASIL. But if you see no other white matter disease on FLAIR in your patient who has long-standing hypertension, and the patient is especially young and has no cognitive impairment to suggest amyloid angiopathy, and particularly if you see callosal microbleeds, you should be thinking DAI rather than these other conditions.
Those hemorrhagic lesions are not the only lesions that you can see. You can actually see changes on T2 and FLAIR. Those lesions, if they're in the right spot, they are just like punctate, hyperintense lesions that are at the gray-white interface. They might suggest DAI. And you can even see them on DWI ADC. I actually listened to your Not All Things That Are DWI Positive or Stroke podcast, which was great. So this is another thing you can add to that list.
I'm so glad this is a audio podcast and not a video podcast. They can't see me blushing.
I think it's great. What's interesting in my mind is that the lesions that you see on DWI and ADC may actually have kind of a correlation with poor prognosis in the same way that the GRE lesions do, but the FLAIR T2 tend not to. What exactly the pathophysiological distinction is between those, I'm not totally sure, but it was interesting that in the literature you can sort of see correlations with the diffusion lesions and the GRE lesions, but not those others.
Also, if you have diffusion tensor imaging at your center, this sequence is probably more sensitive than conventional MR for identifying DAI. But DTI is not a sequence that many providers get in their clinical practice, whether it's to diagnose DAI or to prognosticate following DAI. And the second element, prognostication, is probably more important than recognizing it. What type of information do you use to prognosticate?
I mean, this is obviously the million-dollar question, and there's some really interesting work going on in this area. First, I would say that in general, it does seem that the burden of DAI correlates with poor outcome. So there was a Dutch meta-analysis of over 500 patients from 2018.
A paper by Marlene Maria van Eyck and colleagues in the journal Brain Injury. You'll find it in the reference section of our show notes.
Patients with TBI without evidence of DAI had a 3-fold less poor outcome than patients with TBI and DAI. So,
with poor outcome defined as the Glasgow Outcome Scale, or Glasgow Outcome Scale Extended, indicating a persistent vegetative state, or worse. Translation, TBI with radiographic evidence of axonal shearing injury put you at 3 times greater risk of ending up in a vegetative state, or dying, when compared to TBI without abnormal imaging findings.
And then they actually also looked at the grades.
With grade 1 indicating lobar white matter lesions, grade 2 callosal lesions, and grade 3 brainstem lesions.
And so grade 1 versus grade 2 versus grade 3, for every step increase in the grade, there was actually a 3-fold increase in poor outcome.
Again, meaning a vegetative state or death.
What's getting cooler is that we're also trying to co-locate or localize the lesions and see whether there's any sort of association. And so they found that lesions in the corpus callosum were actually significantly associated with poor outcome in contrast to other locations.
And these lesions weren't just the microhemorrhages we've been talking about.
ADC lesions were particularly predictive of poor outcome.
Meaning the lesions exhibited cytotoxic injury.
There was another study of over 1,600 patients. This is a Canadian study that was published in Critical Care Medicine.
A paper titled The Prognostic Value of MRI in Moderate and Severe Traumatic Brain Injury.
This is really just an MR study of TBI prognosis.
The reference for this paper is also in the show notes.
They found that patients who had DAI patterns, it increased, the risk ratio for poor outcome was increased by 2.5.
In this meta-analysis, the investigators also looked at the impact of brain lesion location on clinical outcomes. Having just a single brainstem lesion, for example, increased the odds of poor functional outcomes by 2.5, with pontine lesions seeming to drive the association between brainstem disease and functional disability.
I suppose if you just think about kind of the density of the white matter tracts, and if there's might be kind of more of a mechanical shear stress at the level of like the mesencephalon, and if you're going down from there, then it really has to be more significant. I don't really know. Admittedly, these pooled analyses are so heterogeneous that whether you can really infer anything, I think, is a little bit hard. But it's interesting just to be thinking about it this way.
Altogether, the findings are unsurprising that brainstem, and especially pontine and midbrain involvement on DAI, carry a more grim prognosis. We also see this in other neurologic diseases like basilar artery occlusion, cavernous malformations, and spontaneous intracerebral hemorrhage.
Lastly, there's a group in Boston who actually did that. They took MRIs from, I think, like 40 patients, and they co-registered it with, they call it the ascending arousal network, but I think the rest of your audience will probably know it as the reticular activating system. So they kind of transposed the patient's actual MR on top of this atlas of the ARAS. And for patients whose lesions were in the dorsal brainstem, those were correlated with worse 1-year outcomes. So it was cool because they had 1-year outcomes on these 40 patients. It's obviously a small study, but the fact that they could look at that, kind of prospectively, but the ones that were either global or in the ventral brainstem or the corpus callosum did not correlate with poor outcome.
One interesting confounder in this well-designed anatomic study is that the investigators observed a 2-fold greater number of total traumatic microbleeds among patients with dorsal brainstem involvement than patients without dorsal brainstem involvement. So could the poor outcomes observed in patients with dorsal brainstem microbleeds have been the consequence of a more widespread and severe axonal shearing? It's possible. I mean, the investigators did not perform any adjusted analysis in this paper, but what they did report in an unadjusted regression was that the global number of traumatic microbleeds had no association with 1-year disability. And like Dr. Kumar said, the callosal microbleeds, while previously shown to correlate with disability, were not significantly associated with long-term disability. P-value was only 0.10, but the effect estimate was similar to what the investigators found for dorsal brainstem hemorrhages. And for more information on the interpretation of p-values and effect estimates, I'd encourage you to check out one of our prior episodes, episode 147 on p-values. And I know we're throwing all these numbers at you, but despite these statistics that should only make you lean one direction or another, these clinical and radiographic findings are not the end-all be-all of your assessment.
Many young TBI patients make a really remarkable recovery. It's not uncommon for patients to be comatose for 2 weeks and then a month out be following commands and even talking. I've certainly seen that. And even with these brainstem hemorrhages, I think patients can do well.
As if that weren't confusing enough, and we only talked about the acute presentation and early prognostic features of DAI, now we're really going to be spinning your wheels. Many patients with mild TBI, mild DAI, they go on and do very well. But for some, things get better only to get worse.
So I think that some of these pathways you can turn into chronic inflammation. I think
this shouldn't be entirely surprising. You've probably heard of the related neurologic condition,
chronic traumatic encephalopathy,
which we talked about in detail in episode 33, as I mentioned earlier.
There's a transition period between, the acute phase and then the more chronic phase, and why it would continue to progress over time. How seizure activity plays into that is unclear, but, certainly we know if it's repetitive, I think it's more likely to happen. And that can mean, obviously being someone like a boxer or football player, but it could also mean, repetitive falls in an elderly person.
We touched on the pathogenesis early in the program today, but let me reiterate what we know about TBI and cellular remodeling. Within hours to a day, amyloid beta plaques can be seen in about a third of patients who die soon after severe TBI. These features do not dissipate with time, but they're more likely to progress and lead to an Alzheimer's-like phenotype. In patients with mild repetitive TBI, like we've seen historically among boxers with dementia pugilistica, there's a prominent tauopathy with deposition of neurofibrillary tangles throughout the cortical gray matter. As a confirmatory finding of this process being unique to head injury, there is sparing of the tau deposition in the mesial temporal lobes, which is often an early site for protein deposits in Alzheimer's disease. There's also often a loss of substantia nigra as well, in the absence of Lewy bodies, which distinguishes this condition from idiopathic PD. And this explains some of the additional motor and non-motor manifestations following DAI and TBI. And there's no great way to prognosticate this among survivors of TBI.
It's like a big black box. You don't really know what's going on in there. And so we just try to monitor from every vantage so that we can really treat the patient in the best way we know how. It's amazing to me that worldwide TBI is the number one cause of injury harm to patients who are young.
Not to mention a rising problem during the COVID-19 pandemic with the implementation of social distancing recommendations and stay-at-home orders.
And so little is known about this disease. And it's often recurrent. It's often, not a one-time disease. And so I think it's imperative for us to really critically appraise this. I remember as a resident, people saying, what's the big deal about TBI? You just stick them in a corner, wait a couple months and see if they wake up. And we've come so far.
We've come so far in that we have incredibly sophisticated neurodiagnostic imaging with high-resolution susceptibility-weighted sequences, diffusion tensor imaging as we discussed, and we have a better sense as to how to prognosticate and counsel families of TBI survivors. But there's still a lot that we don't know, and a lot that we're constantly exploring.
Crucial to that is going to be understanding brain physiology, brain biochemistry, blood flow,
multimodality monitoring.
And I think this is what makes it fun too. So the BOOST trial.
BOOST 3, which is a randomized clinical trial evaluating the use of multimodality monitoring in TBI.
I think it's going to be really informative and we're excited to be a part of it.
Only time will tell if these newer and more sophisticated interventional strategies may be helpful, but we have all the reason in the world to be optimistic. Okay, well, this was a lot of fun and a lot of memories.
Oh, that's great. Thank you so much for having me.
And with that, we'll wrap up another week of the Brainwaves podcast. Thanks so much for tuning in. As a reminder, Brainwaves is intended for medical education only and should not be used for routine clinical decision-making. This week's episode of Brainwaves was produced by myself, Jim Siegler, with the help of Dr. Monisha Kumar out of Studio 3 in Philadelphia, Pennsylvania. Music for our program today was by Rui, Swelling, Unheard Music Concepts, Jazar, Ian Sutherland, and TRG Banks. Our theme song was composed by Timothy Dalton. Voiceover courtesy of Terry Yeager. Sound effects by Mike Koenig and Daniel Simeone. For more information on what was discussed on the show, as always, please take a look at our show notes for the references to the highest yield literature on the topics, and follow us on Twitter at Brainwaves Audio. I'm Jim Siegler. Talk to you soon.